those reimbursement rates for providers taking care of medically fragile patients.
Madam Chair, members of the committee, are you specifically talking about the medically fragile waiver?
I'm specifically talking about the reimbursement to the Anna Carlson Center.
Madam Chair, members of the committee, I know that Chris has been involved in conversation with Tim. Tim was here earlier, there he is. But there's still continued work, as in our, the rate matrix itself does allow for an ICF medically intense rate. And so if those children or any other person residing in an ICF would qualify for it, they would be able to get that rate. But I haven't had any direct conversation with him, so I'm really not at liberty. I don't know what you're.
I think it's that the rate isn't high enough, and so we could make sure the bills are continuing, that would be great.
Madam Chair, members of the committee, I think it's important to remember when we built those rates, it was built on actual costs of what the providers were being reimbursed and under the old system.
Yes. And I have 3 or 4 questions. I think the moving around was one of the things we were concerned about was the movement. Do you have any sense of how many people have had to change programs because of the new system?
Madam Chair, members of the committee, I honestly don't have a definite number for you. I don't believe it has been a significant amount, but I can't say if it's been 10 people or 20 people.
Yeah, because that was a concern, that would cause an unintended consequence. The second feedback I have gotten was that the administrative time to provide the monthly billing data is very burdensome for providers. I've had 3 or 4 providers call me and say the administrative time is much more complicated. And are you monitoring that? And is the turnaround and how is your office coping with the whole new reimbursement system? And they say it's very paper intensive and very time consuming to bill.
Madam Chair, members of the committee, I can speak to some of that. I think it's a variety of issues with that question. One of the things that under our old system, we had just 2 services. We had day rehabilitation and we had extended services. And the federal government had made it very clear in one of their memos that we could not pay clients if they were in day rehabilitation, and we were doing that. And so we had, as a discussion with CMS and information that they had submitted to or sent to us, had made the decision to add 3 employment-related services, so pre-vocational, small group, and individual employment, and then we have day have as well. So you really took 2 services to 4 services, and that is what is causing some of that extra work for providers, because now you just don't have 2 categories to try and track as to which one you're billing under. And some of those services are very close in delivery, so it's a bit more of a tracking issue for providers. We are, working with CMS. I've reached out to our National Association of State Duty Directors to see if there's some other solutions that we can come up with, maybe not changing services, but with the way we are authorizing the services, to come up with some of those solutions. So we are working on that and it would be looking at in our labor review that we're submitting.
And then some of the authorizations were messed up and then so that there's a lot of implementation kinds of problems. But do most of the providers feel like they're getting reimbursed in a timely manner for the services, their tax flow, those kinds of things?
Madam Chair, members of the committee, when I spoke to, I don't remember if it was Bruce Murray or someone else with the Provider Association just recently, they said the MMIS part of it, that is not the problem. I mean, so they are
the billing part.
Correct.
And finally, I'm glad on your outlier report, you talked about the 20 individuals who didn't meet the criteria. That's the other thing I've heard about. So you've got a defined set of criteria, but if somebody has a special need, are there exceptions for those outliers and the definition of what's an outlier, what's the criteria? What's your timeline for reviewing those 20 cases and looking at those definitions?
Madam Chair, members of the committee, actually, prior to us going live, we made changes to our policy and we added a category of special consideration already. So there is a category that if they don't meet any of those others that we have listed, for example, they live in a rural area and there's nobody else that they can share hours with, or they can, anything like that, then they could apply for it under that special consideration. So what we'll be looking at in that subcommittee that I mentioned, and we actually meet on Tuesday of next week, we'll be looking at okay, so why didn't they meet that criteria? You know, what was the reasoning for it? If it was not significant enough or something.
I know part of the concern that I have expressed to you has been 15-minute process. And I know you're doing something with that, but I would find that was onerous actually. I understand the need to figure out whether or not all of those various components are necessary. Is there anything that can be done to kind of simplify that? Is there a nice little app on somebody's phone that they can touch?
Madam Chair, members of the committee, the 15-minute unit, so prior to the implementation of the system, our day half services was an hour unit. And so we actually thought it would be a benefit to the provider to do the 15-minute unit because if they only provide 27 minutes of service, they are not supposed to be billing because they need to hit that 31 minutes of service. So we thought this would be a more beneficial way for providers to be able to bill more accurately for the services they're providing. I think one of the things, our case management system that we have, eventually we plan to do billing through that system. However, because of some complications of our codes that we use for billing, and where we're at with our MMIS certification, we cannot make those changes to our program. So at this point, we're not able to do the billing through TheraP, our case management system, which hopefully at some point will mitigate some of that 15-minute unit. I actually did meet with the Provider Association earlier this week too, just to talk about we need to try to prioritize some of these concerns, so that we can figure out which ones are at the top there to work through. And the 15-minute unit was not one of theirs. It doesn't mean it's not an issue, but it is something that the issue that Representative Hogan brought up is more of a concern.
Other question, Representative Tran?
Thank you, Madam Chairman. And Tina, this number of 470 outliers since the beginning of the year seems like a pretty large number. How does that compare with other states who've implemented this system? And you mentioned that you don't know how many people have lost their placements or have had to change placements due to this. Is that something that we should be tracking in the state?
Madam Chair, members of the committee, yes, it is something that our regional offices are tracking. I just don't have that data with me. And they're certainly the ones that are involved in if there is a need to find another provider or replacement, they're working through that. And as far as the number of them, under our old system, when we had our consultant did our analysis of our previous system, they had said that over 50% of our clients had enhancement requests. So when you look at the numbers, if you look at the amount of individuals, we have 310, somewhere in there, 313 people. And we have almost 3,000 that were impacted by this change. So we're under what we were doing before under our old system as far as I know.
Other questions? Thank you. Coming back this afternoon.
All right, thank you.
Anyone else who wishes to testify on this particular topic? Involving drug abuse? Good afternoon.
Senator Lee, Chairman Lee, members of the committee, my name is Tim Eisinger. I'm the CEO of the Ann Carlson Center. I just wanted to provide some clarification relative to a special pocket of the Ann Carlson population. Our medically complex children are not adequately addressed in the current DD payment system. There are elements, even pursuing to the full extent of the outliers, the medically intensive rate, they're not fully accounted for. There was a consultant that was involved, John Maligas Grubb, who did the initial calculations. He made an error, and that error was passed on to the department, and unfortunately, as I understand it, from the steering committee input as well as the UBI, or Universal Budget Impact, the change was not made. That being said, we pursued all of the medical outliers that we could possibly pursue, but we also started an initiative with Director Jones, as well as Myla and Tuffy from the Department of Health, in looking at a change in classification for those medically complex children. The interest is in using the North Dakota State Health Council and develop a pilot project that would develop pediatric skilled nursing facility category in North Dakota that would address those needs. So we are in mid-process and attempting to reconcile that. Hopefully the solution would be better than working through the DD system, and Chris Jones certainly supports that. But I just wanted to add that testimony as a part of the conversation today.
That's a innovative solution. So anyway, we'll be interested to hear how that goes, because obviously that's a really important area. Any questions, Mr. Eisner? Any questions? Nothing? Anyone else? Anybody else on, disabilities? Any discussion, was there any further discussion from the committee on this? Any further? Kind of discussion? If not, move along. To our 11:20 item, which is about the children's prevention and behavioral services. Thank you. You're ready.
My name is Pam Segnis, and I'm the Director of the Behavioral Health Division within the Department of Human Services. Chairman Lee, members of the committee, I'm here today to provide an update on the House Bill 1040, Children's Prevention and Early Intervention Behavioral Health Services Pilot Project. And the information from the bill is in your handout, so if anyone wants to have a refresher of what that section was, this is the section specific to a pilot project in a school relating to behavioral health services that are prevention and early intervention, and there is a sum of $150,000 to implement that pilot. So I want to go back about a year ago. I provided some updates to this group, but I wanted to make sure everyone was aware of some of the work that we've been doing over the past year. We gathered a group of stakeholders, specifically from education and key partners that we've been working with in really identifying kind of what are the solutions that we can offer in looking at better addressing mental health and substance abuse issues or global behavioral health issues in schools. And so there's been a group of stakeholders meeting that really is a diverse group. I wanted to give you information about who's been part of that. We have school administrators, special education, several state departments. We have representation from urban and rural schools, and it's not a formal group. It's been people that have been collaborating or offering different examples of successes that they've seen in the state. We also basically had this group that was kind of meeting and talking about what are some of the issues relating to behavioral health in schools. And before we could identify a clear pilot, there was consensus among the group that there were a couple of key things that are really infrastructure concerns that we need to address before we just fund a pilot. To ensure that we would fund something first that would be a model that could actually be utilized in a broader sense, and something that would truly meet the needs and not be something that was just kind of a one-year program that wouldn't have sustainability. So I wanted to talk through those 4 areas. There was kind of 4 areas that we identified. We had significant areas of gaps between the behavioral health system and the education system, and often special education. Some of you have heard me talk about the fact that we use different language. So for example, in the school system, there's emotional disturbance or emotional disturbance specialists. And yet that's not a credential that's identified in the behavioral health system. And so there's areas where, we're really not using the same language. There's also, when we work with schools, they'll often say they have a social worker, but not really understand the difference in scope of work between a licensed clinical social worker or someone who maybe is an LSW and those differences. So we spend a lot of time focusing on how do we ensure that we're all using the same language in the right way?
who are really those key people that would have the credential, and what are some of the barriers that we've identified in the workforce in order to truly make gains in how we address the behavioral health issues in schools? What are our goals? One of the more interesting, I think, pieces that really advance our conversations and thinking is that we truly have different goals. The education system, specifically the special education system, has a goal of education. And often they're being put in a position to be managing behaviors that they're not trained for. And often that's the behavioral health conditions that are affecting performance in school. However, in a behavioral health sense, we have a goal of bringing whole and finding recovery. And that isn't necessarily always the same strategies, the same goals, or the same purpose. And so we have had a lot of discussion about if behavioral health services are integrated into school, or if behavioral health services are outside of the school, how do we better align those goals? So that we're really looking at if a child is whole, they may not have those same needs for some of those strategies to perform better in the education setting. And lastly, looking at models. So most people are really familiar now with the Behavioral Health Institute of Medicine model that we've talked about, but there's also the multi-tiered system of support model that's utilized in the education system. And so one of our primary goals is really aligning these two systems, because when you look at the multi-tiered system of supports, it really does align to our prevention and early intervention. So in general, the majority of the population will be served with a prevention service, which means healthy communities, building resiliency, growing protective factors and enhancing protective factors, which is different than when someone starts to show a symptom and you have an early intervention strategy, which is where we have our early intervention system. And then really there's that targeted highest population that has that highest level of need, that is that treatment or often recovery. And then what are those supports at all of those different tiers? And so this is really the two models that we have integrated together so that we're using the same language and really talking about how to make a change that will be sustainable. These are the identified needs that the group has brought forward across the continuum and looking at where the primary gaps are. We recommend that there's improved training and resources for schools and behavioral health professionals overall. Language and certifications do not align. So often we found that there would be a credential that is a really meaningful piece of the system in education, but it's not even listed in our list of behavioral health professionals that we've worked on over the last couple of years, like an emotional disturbance specialist. And emotional disturbance specialist language is actually quite offensive to individuals who are in the behavioral health system, because it's just a term that wouldn't necessarily be used. So there's a lot of opportunities for us to do some training and really identifying resources to better align our systems. Also, increasing utilization of screening and early intervention services. And there was a lot of discussion around EPSDT, which is the early screening program with Medicaid that you guys are probably all familiar with. And so there's continued work on how we can better understand how to utilize EPSDT and looking at screening, so whether those are universal or really identifying that middle tier. There also is a significant need for improved access to clinical services, both within the school and externally when appropriate. How do we ensure that services are available when they're needed and that they are the right service at the right time? So looking at those opportunities. And lastly, there's recovery support services, and there was a lot of feedback that if a child has been out of the home, whether that's in through the child welfare system, or whether that's in a treatment facility, there's really limited support services for reintegration in many areas. And of course, there was regional differences between all of the different partners. So where we're at today is we feel like we've identified the foundational pieces that we need in order to put out an invitation to apply. And so we will be announcing in August an invitation to apply for elementary and middle schools in order to move forward with this pilot project. This is a list of some of the identified criteria that we've established as a work group that we think are vital if we're going to be funding a pilot that has an opportunity to be effective and sustainable. We need to ensure that there's leadership support, that the school culture is supportive of behavioral health, that they have implemented some prevention and early intervention efforts and seen some success with that they have some level of multi-tiered system of support implementation and a readiness to take action, there will be an expectation that there will be implementation within 30 days of the board. So there'll have to be some level of readiness, and it's really not a planning pilot, it's an implementation. And then also ensuring that the school feels that they have their sustainability plans that they can also share. So that next step also is that we have provided all of the information and the work that we've done over the past year to the Children's Behavioral Health Task Force. That task force is bringing forward recommendations both to the legislature but also to the governor's office, and so we felt it was important that the work that we've done also be shared with that group so that it can be combined with future recommendations. There is an opportunity that I wanted to mention also that has come through this discussion is that there are some really great successes in schools. Some of you have seen those in these interim hearings in different places, but there hasn't been a great opportunity sometimes to support schools in sharing those successes and bridging those successes to other schools. And so we think there's some opportunities in supporting the efforts already underway and sometimes offering some support for evaluating those programs. And some of the programs that have been implemented just don't have a strong evaluation component. And so if they did, I think it would be beneficial to us as a state, and then also for them to be able to provide technical assistance to other schools and coordinate with other schools. And then I also wanted to just point out that in the North Dakota Behavioral Health System Study, the HSRI report that's been mentioned many times today, the majority of services for youth are not being provided currently in a school setting. And so I think there's certainly a huge opportunity when we look at connecting to where children are. We need to look at what are the barriers right now to getting those services to children where they are every day, how to have that be in a way that's going to build to their goals educationally and not take away from those goals. And if there's any questions, I would certainly be willing to.
Thank you, Madam Chairman. And it appears, a lot of these positive things you're reporting on that you're doing are actually part of the HSRI report and recommendations. So it seems like the department is sort of taking a chunk of those and is kind of moving on. Is there a plan in your department looking at all 13 recommendations and letting us know or public know which ones, or all of them, that you're going to be working on for the next section? Just talk to us about that.
Certainly. Chairman Lee, Senator Mather, members of the committee. So we will be presenting tomorrow in the Human Services our implementation plan of the report. But I can at least, and we'll ensure that everyone on this committee also gets a copy of that testimony and how we're implementing. What we'll be providing is an overview, number one, of how we achieve goals 1 and 13. In the report, the first goal is about really the implementation plan, and goal number 13 is about how we're going to evaluate our work. And so we have a plan in order to implement and also evaluate. And then we also have taken every division within the Department of Human Services and identified which goals they'll be working on. And so I'll be sharing that with you also tomorrow. So you can identify goal number 5 is being worked on in Medicaid and in Children and Family Services, and obviously collaboratively, but who's taking the lead in some of those strategies. And I agree that this pilot is certainly embedded with the goals of HSRI and the recommendations.
Thank you, Madam Chair. The last slide, says, based on available students data, 5% of services for youth are delivered in a school-based setting. Do you know how North Dakota's data compares to other states in terms of behavioral health delivered in a school-based setting? And do you have a feel for what that figure should be in North Dakota in order to provide their access to kids who might not be able to access it outside? But what should
Chairman Lee, Representative Hansen, and members of the committee, I don't have any specific numbers just off the top of my head. I do know that other states do have higher levels of school-based services. When we look at behavioral health or even integrated services available, both health and behavioral health, I think think our goal right now is that this number should be higher. We haven't had discussion about what the benchmark would be, partially because we still have some policy barriers that we're gonna have to work through. So some of those things being really looking at what's being reimbursed right now from Medicaid. And so we've really been focusing more on what are the barriers to this, whether they're workforce or policy. And so we have to establish a baseline. But I think it's a great initiative.
Thank you, Madam Chair. Pam, I have a couple of questions. Okay, so it seems from the report that you gave us that no middle school or elementary school is at 100% readiness to take action. Is that correct? Like on your one slide here where you're talking about you have under next steps?
Yep.
Okay, so number one, are the rural schools represented on that stakeholder committee that you
Chairman Lee, represented board members of the committee, yes. So there was representation from the North Dakota Education Leaders Group. There was representation from rural consortiums on that. So for example, like Rugby, that's one of the schools that's represented. And so there was rural and urban, but I want to clarify the question. I don't think that I'm saying here that no school has a level of readiness. So I want to clarify this slide because I don't want that to be the impression. These are the things that in the invitation to apply we'll be looking for. Is a school that has demonstrated a level of readiness and is ready to implement a pilot that could move right into implementation, and it's not a year of planning. Often when we receive funding, there's kind of a planning portion and then an implementation. So we're really looking for schools that are in a place right now where they've already been implementing and planning, and they're ready to start implementing it.
So does the school have an option not to apply?
Absolutely. Chairman Lee, representative board members of the committee, we will only be awarding one school.
Okay. Oh, I
This
see.
is one
school.
pilot, one
Okay.
potential.
All right, and then the other question I have is, is an alternative to be able to regionalize services, like say we have a small school in Elgin that can align with a larger school system that has the resources available?
Absolutely.
That would be a question I'll be asked. Okay.
One thing that we talked about, this would be more Megan question, I guess. Those services that relates to the, that would be reimbursed by Medicaid in a community provider's office. Like if that same provider provides this service in the school has to. That's a dichotomy. So anyway, I know that these Anderson is. Hopefully those kinds of things will be addressed. I mean, it's just, as you well know, all over the country, we're looking at providing primary care services in the schools. Dental care, which we have some issues with getting done in North Dakota, be done in schools. And behavioral health is an excellent example of that. Some of the largest schools, ours have something that is very involved